We can fix that. If you just don't know it, we can fix that. But I cannot fix laziness. Like I can't. So the moment that I'm able to make an assessment and know that you're phoning it in, you're just here because the school says you have to be here, then my motivation to want to go above and beyond is kind of like, okay, well, we need to have a come to Jesus at this point, because I need to know you're not motivated by the learning experience because this is not something that's of interest to you, or you're not motivated because your skill level, like you're bored with what I'm giving you. You're interested in something slightly more challenging and more, and that's been my experience. Students that I have had where I felt like, okay, they're not really tuning in. I'm not getting much on my return on this investment. And I have a conversation and it's usually frank and honest. I legit just don't have time to beat around the bushes. So I usually find out sometimes they have no interest in anticoagulation, and I'm forcing them to do DOAC and warfarin education. Other times they have zero interest in heart failure and metabolic disturbances, and I'm asking them to deal with heart failure, diabetes, and CKD. We can figure out what you're interested in. If industry is your flow, yes, I'm in an M-Care clinic. We can work on resource and relationship establishment and getting my clinic more resources, education for the pharmacists that rotate through. I can tailor it to your end. This interview will be no different. The energy you bring will be the energy you get back. You can tell that they're excited about meeting you. They're excited about talking to you because you're excited to be there, right? So the clinical challenge, it has a lot. On this, like I literally couldn't put a list together of every single possibility that exists. But I just think in the last 4-5 years that I've been doing this, people who go in armed with this list and understanding the basic pharmacology of this list, they come out and their response is, I killed the clinical challenge. They tried every trick they knew, and I was prepared for all of it, right? This list is not all encompassing, but the basic pharmacology here, you have to know. The thing is, or the advantage, I guess, that you have with this list is like all of the drugs in these classes have several class effects, right? What you will see with Jardiance, you will likely see with Farxiga. What you will see with lisinopril, you can expect that from any other ACI. What you see with irbesartan, you can expect that with any other ARB. So just pick an ARB, pick an ACE. Like if I could pick a drug and it's an ACE, I would say lisinopril. It is by far the most prescribed drug in its class. With the ARNI, it's simple. There's just one right now. We don't have a lot. We just have Entresto right now, right? With the SGLT2, I would focus on Farxiga and Jardiance because those are the two things right now competing for the space in the heart failure and diabetes management. The DOACs, I would focus on Eliquis and Xarelto. Those are the only two big players that we have right now competing for eligibility of patients based on criteria. Warfarin, it's older than dirt. Just know it. It's got so many food, drug, nutrient, disease, like drug interactions here are going to be how you shine, right? Vancomycin, it's just, it reigns mighty. It doesn't matter what people are showing up with. Until we know something, we're probably going to start with Vanc. And so understanding Vanc, how it works, how we would peel it off and how we would add it back on, how it's dosed. It's major toxicity that we're worried about, the monitoring parameters, the goal troughs. I think you guys are the graduating generation and y'all are gonna look at us like, I can't believe they use trough. But AUC over MIC, I think is a thing that's going to be normalized with your generation. So understanding the difference between AUC over MIC monitoring versus trough monitoring, I think for your generation, AUC will probably be what you guys use and will look at us like, I can't believe you guys used to chase numbers, but that's kind of, so let's see. You are right about switching over. Yeah, okay, thanks Mercedes, yeah. So be familiar. With vancomycin, that's going to be my advice. I think that if they want to be tricky and if they want to test your knowledge really, really well, it's not going to be what is the trough goal. You guys are probably going to engage in an exchange about AUC over MIC dosing with vancomycin because it's cutting edge, it's up and coming. Institutions are literally working on converting and getting away from trough and switching to MIC and what is the benefit of it. I would familiarize myself with that.
I have a question.
Yes.
Sorry. So for the clinical challenge, I guess my question is, do we volunteer this information or wait until it's asked?
Wait until it's asked. Great question.
Okay, thank you.
Sahara, right?
Of course.
Okay, that's a great question. That's a great question because some of these things could come up as you're answering a question like, I don't know, there was a patient case and the patient was on this medicine and that medicine. And before you know it, you guys are having a clinical challenge exchange. And they would ask you, well, what was the issue then? Or what would you have done differently? They're going completely off script, but you are officially in a clinical challenge discussion at that point, right? Or you could come in and they give you your schedule and you'll notice that there's a 30-minute time slot that has been completely set aside where you'd be given a case. You will be given 15 minutes to read and work up the case and have a discussion with a panel of residents, preceptors, maybe the director sometimes sits in, but most programs, they keep the director out of it to just lower the temperature in the room. If you're talking with residents and other preceptors, and then there's your director as well, that could make people way too anxious to be able to think clearly. But yes, it's gonna be very obvious to you like, oh yeah, this is a challenge. They're testing my knowledge on this topic right now. Relevant topics, like a lot of the things that I included here, or some of it from direct feedback I got from last year's interviewers. But if you look at it, these are clinical areas that have seen some guideline updates within the last 3 years, right? I cannot stress this enough. If you are interviewing for residency this year, the least you can do for yourself is to review CHF, diabetes, and chronic kidney disease. All of these other things, I just feel like if you've had strong rotations, you may be able to wing it, right? If you have strong clinical rotations, you've seen C. diff already, and you know that there was an update in C. diff guidelines and deficit is now first, but it's way too expensive. So vancomycin is still the one we go to. You may be able to wing a lot of these things because they're really, really niche areas. But the cardiorenal metabolic syndrome space has seen ridiculous growth in just the last year. Your generation, y'all are going to be the people in M-care clinics that are run by pharmacists for heart failure, diabetes, and CKD management, because that is literally like where we are going for pharmacy. Reimbursement for hospitals are going down the drain. So a lot of hospitals are investing in outpatient clinics and looking for highly trained pharmacists that can run these clinics effectively and keep people out of the hospital. And a lot of that is strictly and directly related to their medication therapy management. This is why med management clinics are blowing up everywhere, because it's turning into a place where pharmacists are making the hospital money instead of our tradition of being a money spending department. But now we are becoming a place that's actually making and saving the hospital money. And that is happening in these three areas: heart failure, diabetes, and CKD. The other thing that should be apparent to you by now as well is if we go back and look at this list, 1, 2, 3, 4 are all related to cardiorenal metabolic syndrome, right? So it may look like, oh my God, I have to learn a whole lot or prepare with a whole lot. You don't, because cardiorenal metabolic syndrome alone deals with like more than half of the things on that previous list, right? Another area where medication is mighty is ACS or post-PCI management. People come in and they do have a STEMI and they end up in the cath lab and they get a PCI. How are we making sure that they are getting their DAPT therapy and the beta blocker is initiated 24 hours after to prevent cardiac remodeling? So it's like you want to sit down and think about where are the places where disease management and success and outcome is directly linked to medication, like directly linked to medication. C. diff, we don't have surgery yet. There's the fecal oral transplant, but that's like last line. To treat C. diff, we need drugs. We need drugs that have to be administered at appropriate dose and for the appropriate course of therapy, duration of therapy, right? So these are popular topics for interviews because medications make the biggest difference in our success or failure in managing these disease states. Heart failure, my personal favorite. It sounds terrible to say, but I love that I can play around with drugs. I can add them. I can amplify it. I can measure labs. I can have them back in 3 weeks and 2 weeks and 3 months. I can play a direct role in making sure that the drugs are so appropriate that this patient can go up to a year with no exacerbations and no hospitalization. It is an undescribable feeling, especially when that patient has come to you after being hospitalized 3 times in the last year. And now your involvement is resulting to an entire year of no hospitalization, right? So your program is going to want to know that your baseline knowledge and some of these is really strong. That's my advice. Just cardiorenal, make sure like they cannot catch you slipping with the cardiorenal metabolic syndrome. I don't know how pro tip number 3 is before pro tip number 1, but this is where we are. I don't know. So case, let me see if it's gonna make sense as I go on. This is the case example. As you're reading this, you're gonna see all of how there are all these holes in it. How about COVID-19? Yes, so I'm gonna stay here a bit. COVID-19, absolutely relevant, right? So we have inpatient management of COVID, I apologize. Why? Sahara, stop. So COVID-19, because it's rampant everywhere, they will want to know that you have some baseline knowledge about COVID-19. The reason why COVID-19 is a really challenging clinical, like it's not an appropriate clinical challenge to pose. We still have no idea why. For certain, right? The people who are vaccinated that are making it after re-exposure versus those that are not vaccinated that don't make it versus the people that have vaccination plus booster, they respond to steroid better versus what about the people who were giving 2 courses of remdesivir too, but no monoclonal antibody? We are still in a learning phase of the pandemic, but the one thing we know is that steroids continue to reign mighty. So that could be a question you're asked. I do not see it. And if it happens, I want to know about it because I'm very curious to know how they would challenge you clinically on COVID-19 as a pharmacy student. Like, how would they pose that challenge to you and what they were interested in you knowing? So, because all of last year, there were 0. All of these, like there were 0 yesterday. And vaccinations, absolutely, Sahara. So, Sahara, I hope I've addressed your question on COVID-19. If I haven't, just comment. Okay, great, thank you. Natalie has a question, and Natalie's question, do you think these topics would differ if your interview is for a community residency? Maybe focusing more on chronic disease state, question mark. Some of these common topics you share seem more specific to inpatient residency, i.e. sepsis. You're right. The difference, I'm just gonna go back to my list real quick. I'm sorry, I'm jumping around, guys. So let's say this list, for example, if you are somebody who's going for a community pharmacy residency, a lot of community pharmacy residencies, the resident is in charge of developing unique and special community health programming, right? And the way that that usually works is data on how much of your patients that come to your pharmacy, which of these drug classes are you dispensing the most? And what are some services that these patients can benefit from? So this list, if you are a community pharmacy resident, absolutely. the rules do not change for you, and making sure that you have very good understanding, because your challenge could be that here's a patient who's been hospitalized several times in this past year, and they're on the following medication, and you're forced to identify potential drug interaction or drug disease interactions to try to minimize the patient's hospitalization, right? Here, yes, pneumonia, community acquired, you're going to be dealing with a lot of drug interactions, right? They're usually coming to you with azithromycin or doxycycline, and you want to make sure you counsel, especially for doxy, with the photosensitivity. Sepsis, 100% is an inpatient issue. ACS, 100% is the hospital pharmacist's job to make sure the patient leaves with those medications. However, if that patient shows up at your community pharmacy and their script is for ADAPT therapy, right? I'm sorry, I'm using acronyms, assuming that everybody would know what DAPT is, but DAPT is just the acronym for dual antiplatelet therapy. I'm sorry, if I'm using acronyms and you don't know what I'm talking about, just put something in the chat so that I can I can adjust the behavior. I apologize. But if that person is coming in and they're a new Brilinta or a new Plavix and aspirin start, there is a huge value in educating that patient on why they're on these two things, especially if they've received the drug-eluting stent, and making sure that not missing any doses are important. And so this list is compiled through a combination of people that applied for AmCare residency, the non-traditional PGY1 AmCare, regular pharmacy practice residency, as well as community residencies, right? And then I think I had a few people last year that went for the PGY1, PGY2 combination pharmacotherapy residency. Those people, 150%, you will have a clinical challenge. There's no doubt about it. I'm gonna check that I answered your question. Natalie, I hope I did. Let me know. Okay, great. Okay, great. If you want to have more targeted conversation with your community residency prep, please let me know. I'll be more than happy to chat further, Natalie. This is our case example. I've already warned you that your case is for, it's 100%. I mean, I'm not going to say 100. I'm going to say 99.9%, it will be incomplete. And it's incomplete intentionally. It's to see if you can pick out what the issues are. 55-year-old male. That's what YAM is, guys. If you see YAM, I don't want you to get all twisted up in your head about, does that mean something else? It just means year-old male. Okay? Present, because I had somebody last year was like, there has something in there that said YAM. I don't know what YAM is. And I spent all this time trying to figure out what YAM is. I'm like, oh dear, I failed. It was my job to prepare you for the weird acronym they'll use. But YAM is just year-old male, okay? And if you see YOF, it's just female. Presents to ED with chief complaint of shortness of breath for the past 3 days, right? PMH includes HFrEF, NVAF, HTN, and T2DM. I use acronyms intentionally because I want to make sure everybody here knows what each of these acronyms are. HFrEF, heart failure with reduced ejection fraction. NVAF, non-valvular atrial fibrillation. We all know hypertension, and we all know type 2 diabetes mellitus. This is the 3rd day of hospitalization when you encounter the patient. This is the patient's home medications, right? All of these little hospital emojis, these are all the medications that have been continued while the patient is in the hospital. These are your challenges. You have 5. Your first challenge is to list all medication therapy problems you can identify. I want to pause here. The question is asking you for medication therapy problems or MTPs. It's not asking you for patient's problem list. This is not number 1, CHF, number 2, HTN, number 3. They are specifically asking you medication-related therapy problems. There is a difference here. It's similar, but there's a slight distinction. The problem list, you're going to work the patient up based on their disease state and categorize it, controlled, uncontrolled, the 2 categories, right? Stable, unstable, worsening, improving, trending up, trending down, so on and so forth. The medication therapy problems you identify: ineffective therapy, more effective medication available, adverse drug event, drug-drug interaction, drug disease interaction. There's a whole category and a slew of categories with medication therapy problems. But you're essentially being asked to just give the problems that you see on the med list a name. I have 2 in the chat. Is there such a thing as doing too much? Like saying not on metformin, but okay, Sahara, honey, you're going too fast. You're going too fast. We're gonna address all of what you just put in the chat. Okay, right? So, and then I'm going to calm down. It's okay. It's okay. The second question is, what is the EF cutoff for HFrEF? And what tests would you need to review to quantify the EF for this patient? This is straight recall, right? This is not asking you about how you think. This has nothing to do with how you process information. This is, I know it or I don't know it. And this is like guess or don't guess time. Because if you tell them, I'm not sure, but I don't want to guess, I would look here to confirm. If I'm interviewing you, I will say absolutely guess. I will force you to guess, because this is like ground zero of heart failure management, and I would expect you to know it. And if you don't know it, I want that exposed, right? That makes me a horrible interviewer and a mean one, but I would force you to guess. So make sure that you know what your heart failure cutoffs are. It's one of the bonus points you can earn because it's easy to memorize, right? What assessment tool would you use to determine if this patient is indicated for full AC for their NVAF? That's your third challenge. Do you have recommendation at this time for this patient's pharmaceutical care plan? For any medication. Number 5 is really more of, they throw you a bone and say that for all of the medication change you recommend, you have to list a minimum of 2 counseling and safety monitoring parameters, right? That should go without saying. Number 5 should go without saying. Anytime you make a therapy recommendation, that therapy recommendation needs to be coupled with, here's what I'm going to monitor for, here's I'm going to educate the patient for, and I want to reevaluate the patient's X, Y, and Z in 2 weeks and 3 months and 6 months and whatever. So just get into the habit of knowing that anytime you make a change, it should come with safety and monitoring plan. Okay. What's AC? Yes, AC is anticoagulation. Great question. I want to know them. As you see the acronyms and you're not sure, absolutely drop it in the chat. So we're back on track. Pro tip number 3 is there, but I'll review it again. So look for objective data to support each past medical history or acute problem, right? They could intentionally, all right, I'm gonna tell y'all something. When I interviewed and I give a clinical challenge, we literally had a separate sheet with us where we waited for the candidate to ask for the labs. It's dirty, but we were a bunch of little residents and it was dirty, right? That is just mean. I know it's mean, but it's like in our mind, it's like, how are you going to just start making therapy recommendation when I didn't give you any labs, anything, so we're just gonna sit here and wait to see how you're gonna pull off this miracle without labs. If they don't give you labs, ask about labs. If they tell you no labs are available at this time, we just want you to identify the therapy problems, right? So then you can move forward, But just at the odd that you're dealing with like mean residents like I was, ask for the objective data. And here, let's say for the labs, more likely than not, a Chem 7 or Chem 8 is going to be enough for you to be able to assess, because the number one thing we check for is the patient's renal function. The chem is going to tell you that, and you'll be able to move forward confidently. Imaging results. If it's pneumonia, people actually ask this, what objective data or what imaging result do I need to see to confirm a diagnosis of pneumonia? It's going to be a chest x-ray. The patient's vital signs are important to tell you what their O2 sat is, especially if they're coming in with respiratory infection. You want to know what the O2 sat is. You want to know their blood pressure, their pain, their temperature for any infection. You want to know all that. Vitals are going to help you make decisions confidently. If I tell you patients has type 2 diabetes without a hemoglobin A1C, you should pause. Like, okay, how do I know if A1C is not 6.5 and truly patient is pre-diabetes? How do I know that A1C is not 12 and patient is above 10 and then patient needs insulin now? Like, how do I know what drugs to start? How do I know? I don't. A1C is very important in helping me decide what drugs or time, what time is it? Like, is it time for metformin plus something else, or it's metformin, insulin, and then we can figure out all this other stuff later. Echocardiogram for anybody that has heart failure, the echocardiogram is what's going to tell you what the patient's EF is. That was one of your challenges, right? One of your challenge question is, what imaging result do you need? The echo is what you need. Blood cultures for infections, urine cultures for infections kind of go without saying. Even if your patient has a wound infection, always look at the blood culture, because it's possible that the wound culture has now turned into bacteremia, secondary, blah, blah, blah. Urine cultures, it's possible the patients become bacteremic secondary to what's growing in the urine. So data is your best friend. Just ask for it, because you don't know if you're facing residents like I was, and we're just gonna mess with you. We talked about this already. Your case could be incomplete. That's okay. As long as you're on to game and you know it's okay that I don't have everything, and don't panic, because what happens is people start panicking and they're like, oh my God, I'm missing something. It's right here. It's right in front of my face. Where is it? Okay, what does this mean? Okay, but it says the patient has a dry cough. Is that a hint? Like, what is, your case could be incomplete. That's okay. It's intentional. Yeah, you may not have objective data, or you have minimal, right? It's to see how you think. Like, if your plan involves starting a medication that would lead to changes in lab, ACE and ARBs are notorious for that. Your plan must include obtaining baseline. This is where you recover to make sure that they know that, yeah, you know that you don't have the information you need, but your plan includes getting that information. I want to make sure like that's clear, right? Your plan could be to obtain or initiate an ACE or ARB, but that plan is contingent upon you having baseline CMP, because one of your monitoring parameters when you initiate an ACE or ARB is to check to see the degree of change in renal function, and to check to see the impact of the ACE or ARB on the patient's potassium. You're not going to be able to assess impact or change if you don't have baseline labs. This is why baseline labs have to be part of your plan for whatever you choose to initiate, especially if that's ACE and ARB, because those are the two that are most commonly included or addressed. All right. So now, the pro tip number 3, really, it was to list your problems or your medication therapy problems in order of the most acute or most problematic. The way you figure out that you have a most acute or most problematic, the most acute or most problematic case is to look at, why is the patient here, right? The patient shows up with shortness of breath, and then they have CHF, boom, I'm going to look at the CHF drugs first. I'm going to look at CHF and make sure that all the drugs for CHF are in line and up to date, because if they're not, that's the first thing I got to target, because that's what's led to hospitalization. Right? I'm going to check the chat before we get into the nitty-gritty of this one. Challenge number 1, your medication therapy problem. I want to see them in the chat, please. I want to see everybody drop. I think I came up with a total of 6, I believe, so there's plenty. Type in what you identified. Let me go back to the case so that it's in front of everyone. What do you see as medication-related problems for this guy? All right, chat starting to fire. Ibuprofen, metoprolol tartrate, CB-succinate. I love it. Eloquent should be BID, guys. Beta blocker change. Diltiazem, Amina. Yes, with CHF. Yes. Okay, you guys, I'm like so excited. Y'all are ready. Y'all are really ready. Awesome. Eloquent should be twice a day. I guess that would be number 7, and I missed it. So great job for whoever picked that out. Let's see. So here are what I have. This is what I came up with. So you could see more. And if you see more, yes, please drop it in. I have drug disease interaction with the ibuprofen use in heart failure, as well as diltiazem use and reduced ejection fraction. If that problem is not clear, or somebody would like me to elaborate a little about the drug disease interaction, please speak up. I swear this is a safe space. It's judgment-free. Type in the chat. Silence means we're good. I do have a chat. Oh, you said the hospital emoji means, oh, no. Okay, hospital, I apologize if I confuse. Let me go back.
No, I missaid it. Sorry. If it has the hospital, it is being used. If it doesn't, it's not being used.
Correct.
So the beta blocker doesn't have the hospital.
It does not.
Okay. So it's a home med list that isn't being used. It got stopped.
Correct.
Okay, thank you.
Yeah. Okay. So let's see. Explain, please. Absolutely. So problem number one explanation. Ibuprofen, along with other NSAIDs, and this also includes the COX-2 selective Celebrex. These medications, with their anti-inflammatory properties, are not safe in cardiovascular disease. They're not safe for the kidneys, and they're definitely not safe for heart failure in particular. They lead to exacerbation or worsening of heart failure symptoms, right? So your notes there should be all NSAIDs, as of right now, as far as I know right now, there is not a single NSAID on the market that is appropriate for use in CHF, right? Meloxicam, naproxen, Advil. The reason why we focus on the ibuprofen, Advil, and naproxen is because those are over the counter, and the patient can easily walk up and pick that up. We want to counsel new onset heart failure, even existing heart failure. You'll be surprised, patients that have had heart failure forever, that they say, well, I use ibuprofen because it's the only thing that works for my arthritis. Unfortunately, we are going to have to figure out other ways to manage your arthritis, because ibuprofen is far more dangerous, right? And the idea here is that with each heart failure exacerbation, your heart goes through a series of cardiac remodeling. We don't want that. We don't want that. The muscle is already stiff enough. So any medication that can worsen exacerbation or even induce an exacerbation, we have to make sure we counsel the patient to stay clear of those drugs. It's just a no-go. Diltiazem worsen heart failure symptoms. This is very, very profound in patients that have reduced ejection fraction, right? Diltiazem, I'm gonna ask for somebody to drop it in the chat. Is it a DHP or a non-DHP calcium channel blocker? Because this is a common question y'all are gonna get, guys. Non. Yes, absolutely. I don't know if anybody's taught you this trick already, but if it's a non-DHP calcium channel blocker, it does not have an N in the name. It's super corny, and I think I teach it to all my children, Lord, my students. my students that are in here, please don't come for me. I apologize for saying my children, but I teach my little corny code to all of the students I have, because it helped me through my boards. It helped me just not have to memorize a list, right? If it's a non-DHP, it does not have an N in the name, N as in Nancy. My non-DHPs are diltiazem and verapamil. My DHPs absolutely have N in it, amlodipine, right? Nifedipine, they have N in it. That helps me just separate the classes completely. Just by looking at the name, I know, okay, like this is my non-DHP. Non-DHPs, particularly diltiazem, that's the one that's been extensively studied, right? Its effect on preload is detrimental in patients that have heart failure. We don't want it. I don't care if they've been on it for centuries. I don't care if it was just started last week. I fight to get it off and get it out of there. The evidence is just way too overwhelming to continue it in heart failure patients. It needs to go. So that's problem number one. That's the biggest problem right now. The biggest problem right now is that you have this patient who's coming in with heart failure exacerbation, and they're on medications that can make that worse. We have to intervene and get those drugs removed completely. Whether they're being continued or not, they need to go. Drug-drug interaction, ibuprofen, you guys pick that up. Ibuprofen with Eliquis. Reason number 2 that the ibuprofen needs to go, right? You have a patient on an anticoagulant who's also taking a medication with known increased risk of GI bleed. It needs to go. This patient needs to know that besides Tylenol, they can't do anything. The beta blocker is not continued inpatient. Does anybody know why this is problematic? Because what everybody tends to remember is that beta blockers should not be started during exacerbation. You're right. But this patient, why is the beta blocker not continued? Rebound. Sahara, please clarify.
Can I pass it along?
Can you what?
I thought that you can't abruptly stop beta blockers because they cause like rebound. Like if it's supposed to slow the heart rate, then it will increase. If it's supposed to lower the blood pressure, it will then increase.
So you're probably thinking Klonopin.
Okay, let me just be quiet then. I tried to pass it off.
Listen, it's okay. Rebound hypertension, right? It will cause severe hypotension. Nice try, number 2, Amina. That's not it, right? So what you want to remember here is this is, oh God, my shredder. I'm sorry, my shredder just came on. I apologize. I'm turning it off. All right, my shredder. Because the patient is on tartrate instead of succinate. Very close, Joycelyn. Decreased heart rate, kind of. Hypotension. If EF is low, it will decrease the ejection fraction. Cardiogenic shock, Kristen McNutt. Okay, listen, y'all, we're gonna go through it. A lot of these are around it. The cardiogenic shock is the closest. Orthostatic hypotension, no. So let's see. Cardiogenic shock is my favorite, second closest to the right answer so far. So this is the because succinate is more preferred. That is accurate, but that is not the problem I'm picking out here. That's a problem for later. The problem I'm picking out with the beta blocker not being continued inpatient is that what decreased cardiac output? Yes, very good. The more answers that come in, the closer we're creeping to it. Very good. So in heart failure, the reason why we put patients on beta blocker is very similar to why initiation of beta blocker after an MI is super important. Beta blockers are not great blood pressure drugs. They're just not. If you think about your 4 blood pressure classes, beta blockers are not on there. Beta blockers are only indicated if the patient has a compelling indication. And I think that is the exact language used in the guideline. They say compelling indication. And the compelling indication is structural heart disease, post-MI, and congestive heart failure. The reason beta blockers are so effective is 1, because of their decrease in contractility of the heart muscle, they decrease oxygen demand in the heart, right? Patients with heart failure, their hearts are beating really, really fast. And that increases oxygen demand because the heart has to be in diastole. Remember, diastole, the relaxation phase. Your heart has to be in diastole long enough for the coronary arteries to be able to feed the cardiac myocytes the oxygen it needs to be able to go through its normal ATP cycle for energy. It's a muscle, just like anything else. So when the heart is beating so fast, that chest pain and everything else you're experiencing, it's because of the decrease in oxygen supply to the heart. So the first thing we want to do is to slow the heart down so that the coronary arteries are able to feed it. They also help with something called cardiac remodeling. I hope some of these terms sound familiar. So when someone comes in and they are acutely decompensated with heart failure, and they are stable. They were on a beta blocker at home, and they're stable on their beta blocker at home. We do not take that beta blocker away. Okay, DEA, sure. I'm not sure yet, DEA. I'll let you know. But this is the beta blocker, continuation of beta blocker actually helps. If the patient was on a beta blocker before they were exacerbated, because the heart rate, it helps with contractility, it helps with oxygen demand, and it helps with preventing cardiac remodeling. That's the first concept you have to understand. This only works if the patient was on it at home and they come in. It doesn't matter how acutely decompensated they are. Do not let them take the beta blocker away. It actually makes things worse if they withdraw it during exacerbation. What you all are thinking about is if the patient is not on a beta blocker at all, so new onset heart failure, and they come in, they're acutely decompensated, we're just finding out now that they have heart failure, initiating a beta blocker in that patient is dangerous at that time. We have to make sure that we get the patient euvolemic first, and then we can initiate the beta blocker. This has got to be clear, because this is a major opportunity for you to like just score major points and really, really show off, right? It doesn't need to be super complicated when you explain it. The patient was on a beta blocker at home. They're showing up acutely decompensated. We should continue the beta blocker because it helps with decreasing cardiac contractility and oxygen demand, which can be helpful when the patient is in an exacerbated state. That is it. Questions? Because we will address the salt next, right? That's number 4. We will address the salt next. The people who talked about it should be succinate, not tartrate, 100% accurate. 100% accurate. It should definitely be succinate. Why? Can anybody say why in the chat? Why do I want succinate and not tartrate? Okay, let me check. Studied and mentioned in guidelines because it's extended release, longer acting. Okay. It's the only such studied and mentioned in the guidelines. Close. Long acting. So it's not necessarily, it has mortality benefit. Thank you, Stanley. That's it, right? Your answer is very simple. We want metoprolol succinate because it is the metoprolol salt that has demonstrated mortality benefit in heart failure treatment. You have 2 other options, and those other options for beta blocker is carvedilol and bisoprolol, right? I always challenge like people when I'm talking to them about beta blocker therapy and heart failure in that, when would you choose carvedilol over metoprolol in a patient that has heart failure? It's simple. If you think about it, carvedilol, beta blocker, it's non-selective. It has beta activity as well as some alpha. So in a patient who has heart failure, who's on metoprolol, and you've been titrating, you cannot seem to get the patient's blood pressure. BP control, Nancy, very good. You cannot get the patient's blood pressure under control. Then at that point, you could try to put carvedilol on and just lose the metoprolol altogether because you get more bang for your buck. The carvedilol gives you the beautiful beta activity and decreasing contractility while working on alpha receptors and giving you beautiful vasodilatory properties, right? Like these are all gems you can use to just show off, like really just be like, I don't just have good command, but I have mastery of the topic that we are talking about. So these are like those little points you can score yourself, right? Lisinopril, there's a more effective medication. Can anybody tell me what the more effective medication I'm thinking about is? Yes, Entresto, yay, Arnie. Okay, good. So it looks like everybody's already aware of the almighty Arnie, and we're not going to get too much into it. Another brownie point is, do you know how to transition somebody from lisinopril to Entresto? One, safely, but two, appropriately, because there is a dosing recommendation on how you have to do it. Sahara already pulled us into the diabetes management. The patient needs additional medication therapy. Yes, washout period is blowing into the chat. Very good. The additional medication therapy needed is for type 2 diabetes. Like, this patient is on nothing, like nothing at all. And there's a lack of target dosing. Like, all of the heart failure meds that the patient is on, none of them were near target dosing, right? Beta blocker, only 12.5 BID. That's way below target dosing. Lisinopril, only 2.5, way below target dosing. So familiarize yourself with what the target dosing in heart failure is, particularly with beta blockers, because now lisinopril, I can tell you, you can just eliminate that completely and just recommend initiation of Entresto, right? But I would learn what the target dosing is for the beta blockers, all three of the beta blockers, so that your arm, again, this will be another bonus. The cutoff for the heart failure reduced ejection fraction. Now, 40%, a lot of the literature would say 40 to 45%. Listen, depending on where you work and what your population is, but we can all agree that once they fall below 40, they are officially HFrEF. That's it. If you're 42, if you're 45, there's still a little bit of debate. It doesn't matter. But for pharmacists, we're really eyeing that threshold. Yes, so you do use resources, right? Like here, I reference AHA because I know that that's the reference like I always tend to use for heart failure. I really do go to AHA. So like for diabetes, I pretty much live and die by the ADA guidelines, right? I know ACC is an option. I tend to refer to ACC more if I'm like looking for hypertension, because I know that their guidelines are way more comprehensive with comorbidities and chronic disease state management with hypertension goals. But AHA, to me, not only are the recommendations straightforward, but they're a lot easier and more straightforward with application for clinical practice, in my opinion. Like, I'm sure everybody has their own preferences. For pharmacists, the EF of 35%, this is really where we start to kind of be like, we need to add an ACI or ARB. Like, at this point, this is no longer just a good idea, it's a mortality benefit situation. But what's happened in the last year is that we now have Entresto where it doesn't matter what the patient's EF is. We literally don't care what the patient's EF is to decide if they need some kind of angiotensin receptor acting agent, because Entresto is now both for reduced and preserved. So if they're coming in, even if their EF is 55% and they're on lisinopril or they're on losartan, I will reach out and say, hey, this patient is already on our New York heart failure classification spectrum. Could we initiate Entresto? And I would look at what the lisinopril dose is and do the appropriate conversion for what the appropriate initiation would be for Entresto. That's a place where you could really show off, because there are recommendations. You can't just start at 24, 26, but based on the patient's ACI dose or ARB dose, you can decide what the appropriate dosing is. And we've talked about this already a little bit. The echocardiogram is the way. What assessment tool would you use? Put in the chat. What's the assessment tool? Where's the chat? Yes, CHA2DS2-VASc is correct. CHA2DS2-VASc is correct. We want CHA2DS2-VASc, and the cutoff we're looking for is score of 2 or greater. And so, like, if I'm interviewing you for this case, I would ask you, what is this patient's actual CHA2DS2-VASc score? Right? With some 2s, yes. I would ask you, what is this patient's actual CHA2DS2-VASc score? But I'm just thinking back about his medical history. Heart failure, even though he's young, right? Heart failure, hypertension, diabetes, I'm done. They need full AC. I'm not even gonna put myself into figuring out what the exact number is. They need full AC. So here, your long-term options are really DOACs or warfarin. Depending on which one you choose, you have certain things to consider. If you choose a DOAC, the price is the biggest thing for you to make sure that the patient can handle, but it doesn't have any monitoring needs at all. Versus warfarin, if cost is a problem, this is probably the best option for your patient. And know what the INR goal is. What is the INR goal? If the patient is starting this for NVAF, what's the INR goal? Uh, 2 to 3, yes ma'am, 2 to 3. And really, for warfarin, when unsure, say 2 to 3, because it's highly unlikely that you'll be wrong if you go 2 to 3. When unsure, go 2 to 3. Unless the patient has a mechanical valve, 2 to 3 will be the right answer. For in the hospital, it will either be a heparin drip or Lovenox. The biggest difference between these two, Lovenox is renally dosed, heparin is not. If the patient is going for surgery, we will likely do heparin because we can hold that for 6 hours and surgery can move forward. Lovenox lasts slightly longer than heparin does. And heparin's monitoring, you have to, and I think that was one of the questions, you have to monitor this depending on your institution. They could be using APTT versus anti-10A levels. So this is like a whole clinical challenge area all in its own. Which one do you use versus based on the patient's renal function? How do you dose for Lovenox for full AC versus DVT prophylaxis based on the patient's renal function? It's a whole thing. This tends to be more common if they're going to give you a full case. They'll give you a full case on Lovenox, but with heparin, sorry, I don't know what just happened. But with heparin, they would have to give you their protocol and you have to look at that protocol and interpret it. It's just way too much hassle for a clinical challenge where you only want going on for 30 minutes at the most. What recommendations at this time? So some of you actually, as I sit here and talking to you, I spotted more problems as we talked about it that I have plans for, right? We're gonna stop the ibuprofen and recommend acetaminophen instead. And we're gonna continue Eliquis BID. So Eliquis was wrong. This should be increased Eliquis to 5 BID because that was one of the problems because he was daily before. So please make a note of that the Eliquis is not just continued, but it should be increased. That should be the appropriate recommendation language for that. BB not continued. So the beta blocker should not be interrupted and patients admitted previously who are stable on it. Tartrate is not mortality benefit. We will discontinue tartrate and initiate succinate once daily dosing or same dose and frequency. Now, the way you would convert from tartrate to succinate, the easy thing is, especially for a residency interview thing, the summation of whatever they were on daily, whatever they were on with the tartrate, the summation of that as a total daily dose, and you recommend that once a day for metoprolol succinate. Reality is, in practice, metoprolol succinate, it doesn't last that long. You can dose it twice a day. So because my patients are super old, I tend to take whatever the dosing was for tartrate and give that same exact thing BID to start and see how the patient does. Because I don't want to switch somebody from 12.5 daily to 12.5 BID to 25 daily, and then now the patient's complaining of dizziness and lightheadedness and they're old, I don't want them to fall. So I would keep them on 12.5 twice a day, just to spread the kinetic of the drug out and make sure that the patient stabilizes for 2 weeks, and then ask them if they're open to just switching that to once a day and educate them really, really well for safety at home. My experience is they do just fine, even when I have 80 years old, but above 50 milligrams a day, I split it into 2. As a student, you're not going to have that level of comfort with converting drugs. Your plan is always just going to be, if it was 12.5 daily, we're going to do 25 once a day. All right. The more effective medication available, patient may benefit to switch from an ARNI for its cardiovascular and hospital prevention. We will discontinue this and start 24-26. Now, the rule is this. If your patient's total daily dose of lisinopril was less than 10 milligrams, the initiating dose of Entresto is 24-26. If their total daily dose was greater than 10, you start at the 40 milligrams or 42, I think it is, yeah, and titrate up. Verapamil or any ARB, I think valsartan is the reference drug, and the threshold for that is 160 milligrams a day, right? So if you're given a patient case, this is another place where you could flex. You could low-key flex and say, because the patient's total lisinopril daily dose is less than 10 milligrams, I'm going to initiate Entresto at 24-26. That would definitely be something where I'm like, oh, well, okay, then. Type 2 diabetes. So why don't we care what the patient's A1C is? Why don't we care here what his A1C is? Or let me not say we don't care. Yes, heart failure, new guidelines. Yes, yes. Fatiha, I hope, I pray to God I pronounced your name correctly. I pray to God I pronounced, and if it's incorrect, please let me know. Heart failure, new guidelines. Guys, please remember this. Gone are the days where we are treating our patients and compartmentalizing their disease states. That's over, right? The diabetes guidelines just got updated in December. I strongly encourage you to take a look at it. A few things have changed. And the biggest thing is that there is overwhelming evidence now that says we need to be treating our patients for cardiorenal metabolic syndrome, CRM, cardiorenal metabolic syndrome. That's what we should be treating. We should not be treating our patients for diabetes or treating our patients for heart failure or treating our patients for chronic kidney disease, because all of these three diseases, they coexist together. Rare do you find patients that have diabetes who don't already have heart disease. Rare diabetes who don't have CKD already, or CKD who don't have some degree of cardiovascular disease, right? And so the new diabetes guidelines basically tell us that where before the recommendation was that if they have type 2 diabetes, if they're pre-diabetes, we're just going to start everybody on metformin. Regardless of what your A1C is, boom, metformin is first. The new language says now, well, if the patient has other comorbidities like heart failure or chronic kidney disease, and they have diabetes, and SGLT2 may actually be a good idea. Like, we do metformin plus an SGLT2. Maybe this monotherapy approach in patients who have multiple comorbidities is no longer the best way to go, right? So this is a game changer with respect to how we as pharmacists recommend drug initiation, right? Before, it was very simple. Like, if you go on an interview, type 2 diabetes, and you say you want to start metformin, it's not the wrong answer. It's just, in this guy, you have evidence of hypertension, non-valvular AFib, heart failure, and type 2 diabetes. It doesn't matter what this guy's A1C is, we are going to start an SGLT2 for its heart failure benefits, right? And we are going to start the metformin for all of the primary inflammatory benefit and its beautiful 1 to 2 A1C reduction. But there's one more thing that this patient is a candidate for. They had to think of it when I came around. Janine, they just had to make sure it was a little bit challenging for you, honey. It's because they know you can handle it. That's why they made the change, right? There's one more thing. Yes, Nancy, beautiful. This patient's got an ASCVD risk score that I bet my life is not less than 25%, right? I don't care that he's 55 or 35. It doesn't matter how old he is. He's racked up so many ASCVD risk score by just having hypertension, and you add type 2 diabetes to that. Statin therapy is no longer just a good idea, it's best practice guidelines. He needs a statin therapy on board as well, right? How did you remember this med list all this time? Like, oh my God, Sarah. I'm trying to focus on the people that have questions. Stop. So I really, really want to pause here because there's a shift in paradigm, guys, in the way diabetes is managed. There's a shift. And the shift, it happened a month ago in December. Your RX Prep book does not have it in there. So you're going to walk into these interviews and either answer these questions based on what's in your RX Prep or what's actually current. And I think it would just look very good if you are current. Or if they ask, what is the last journal article that you read? Oh my God, please flex. The recent diabetes, the recent diabetes guideline updates, right? And then talk about like 2 or 3 things that just came out in those guidelines that have changed. I had a student make a table. It's a very beautiful table. And it has old guideline recommendation and new guideline recommendation. Let me know if you want a cheat sheet. But it's a summary essentially of what was old, right side by side with what is new. And it's very simple, guys. The biggest change they've made is one, metformin no longer reigns mighty. It's metformin plus, does the patient have this? Does the patient have this? Does the patient have that? Right? And then, does this matter? Like it doesn't matter in this case. His risks are just way too much. Okay, everybody's saying, yes, I would love that. We're back to that same problem I was having last week. So this is actually our current resident at our hospital. She did a presentation and it was a new onset diabetes case and we had her focus on guideline update. It was a very good presentation. I may just show it for a quick minute and then figure out how to share that table. Maybe I'll share the table on Instagram